Hello everyone. Today we will be moving on to the new topic, that is clinical features and global malabsorption. So the first thing here we will be seeing is global malabsorption, and then we will be moving on to the clinical features about it. So what is global malabsorption? Whenever the absorption inside the small intestine is getting hampered due to the dysfunction of the layer of the small intestinal mucosa, we can say that the patient is suffering with global malabsorption. The substances which are malabsorbed here are carbohydrates, fats, and proteins. The fats is most sensitive and most specific, most energy dense nutrient here. And this causes due to the intestinal mucosal dysfunction. And why is the intestinal mucosa getting dysfunction? It is due to three diseases, which is first is celiac disease, and second is the Whipple's disease, and third is the tropical sprue. Now, what is celiac disease? It is an autoimmune response to indigested gluten, which dysfunctions the small intestinal mucosa in a genetically susceptible individual. It is called as celiac disease. In celiac disease, majority the gluten is kept undigested and it triggers an immune response for the dysfunction of the small intestinal mucosal layer. It is also known as the celiac sphere, gluten sensitive encephalopathy, non-tropical sphere. Till 2023, this celiac disease was misdiagnosis because it has the same symptoms as the symptoms in malabsorption. So majority the doctors, the physician were unaware about this disease. This occurs due to the presence of marker on the gene. This is MHC2 gene marker, which is HLA-DQ2 and DQ8. Most important predisposition. These are the two genes which are responsible for causing this celiac diseases. So there are basically four types of celiac diseases. First is the classical celiac disease. Second is the atypical celiac disease. Third is the silent celiac disease. Fourth is the latent celiac disease. In 50% of the cases, the celiac disease, classical celiac disease, will have the symptoms of malabsorption. What are the symptoms of malabsorption? First is the osmosis, second is the weight loss, and third, the individual will suffer with foul smell in the stool. Second is the atypical celiac disease. Here, the symptoms are other than the symptoms of malabsorption. Like you will see cerebral in the cerebellum, there will be the deposition of calcium. You will see there is a secondary parathyroidism. These are not related to the malabsorption. Still, it will be appearing in the atypical celiac disease. Then third is the silent celiac disease. This is majority asymptomatic, but the serology is positive. Whenever you will take the blood, it will show that this person is suffering with the celiac disease, but there are no symptoms of that disease. So this is silent celiac disease. Fourth is the latent celiac disease. In latent celiac disease, the serology is negative. The individual is not suffering with any symptom, but still he has a high risk of getting into classical celiac disease just because he has the susceptibility to HLA gene. That's it. Presence of HLA susceptibility is the only thing that we can say that the patient might have been suffering with latent celiac disease. Pathophysiology. So first of all, we'll consider this HLA-DQ2 gene and DQ8 gene. These are present inside the individual. These genes are like loaded gun. I'll tell you, it's very terrible. These genes are like loaded gun. And this gluten, whenever you will consume this gluten inside the food, what are the gluten-rich food? That is wheat, barley, rye, oats. Whenever this gluten will get inside your body, it will act as the trigger for this loaded gun. And this gluten is toxic. This will help in the dysfunctioning of the small intestinal mucosal layer, and everything will be destroyed. So this gluten is then converted into gelatin when it goes inside our small intestine. It is converted into gelatin, and this gelatin consists of glutamine and proline. So glutamine will go and activate the polymeric IgA antibody. So here it is acting as an toxic. Now this glutamine has entered inside the enterocyte cells, and enterocyte cells has the presence of this tissue transglutaminase enzyme. This tissue transglutaminase enzyme, what it will do deamidation of this glutamine in the intestinal epithelium, and it will be converted into deamidated glutamine dipeptide. This deaminated glutamine dipeptide is also toxic for the body. It will move inside and it will activate T cells. It will give an immune response to T cells, immune response to T cells. And these T cells will start destroying the small intestinal mucosal layer. It will cause atrophy of the villus. It will cause hypertrophy of the crypt of Lipperkin. The thickness of the intestine will remain normal as per the same, but these two things will be getting tremendously affected, and this will lead to the classical symptoms of the celiac disease. Here are two factual points that we should remember. First is the monomeric IgA is produced in the bone marrow. It is just a factual thing that you should remember. But whenever you will see the malabsorption of vitamin B12, magnesium, and bile acids, you can't say that the patient might have been suffering with the celiac disease, because these three materials are absorbed in the distal part of the small intestine. They are not absorbed in the proximal part. Proximal part consists of duodenum and jejunum. So majoritarily the duodenum and the jejunum part is getting affected, not the ileum part. These vitamins, magnesium, minerals, and bile acids are getting reabsorbed in the distal part of the small intestine. The features of the celiac disease are not seen here. Then what is disease progression? So a patient came to you, he's telling you that is suffering with celiac disease. What he is telling you, you will tell him that he's suffering with celiac disease after having a lot of tests, after having a diagnostic test. And now you have sure shortly know that he's suffering with celiac disease. What will be your first response? You will stop the gluten present in his diet. If he will take a gluten-free diet, he will get recovered on its own, because gluten was the trigger for the loaded gun. So now the patient is gluten free. In 3 weeks, the clinical symptoms will get disappeared. Within 6 months, the histological representation will also get disappear. But in only 90% individuals, not only 90%, the majority of the individuals, but in 10%, the symptoms are not getting disappeared. They are constantly remaining there. So you will say that the patient might have moved into refractory celiac disease. In this disease, the patient can't recover. But if you prescribe steroids, the patient have a chance to get recovered. So there will be no improvement in the refractory celiac disease, even after stopping the gluten diet. And you can prescribe steroid for that purpose. Then there are clinical features of typical celiac disease and atypical celiac disease. So, in typical celiac disease or classical celiac disease, you know that it will mimic the symptoms of malabsorption. First of all, it will cause osmotic diarrhea. Second, abdominal distension. Third, foul smell. Fourth, weight loss and inflammatory bowel syndrome. But in atypical celiac disease, the individual is suffering with the symptoms other than the symptoms of malabsorption. Other than the symptoms of malabsorption as well. He is suffering with the symptoms of malabsorption, but symptoms other than the malabsorption are also occurring here, like short stature and failure to thrive. In pediatric, in children, there is tremendous amount of loss of weight. You can see this in atypical celiac disease. If vitamin D and calcium is not absorbed, what will happen? It will lead to fracture. It will lead to osteopenia, which is decreasing in the bone density. If the vitamin D and calcium is not absorbed, it will lead to secondary hyperthyroidism. If the vitamin E is not absorbed, it will move to ataxia and peripheral neuropathy. What is ataxia? There is no muscle coordination, that is referred to as ataxia. Peripheral neuropathy, the peripheral nerves in the spine, the peripheral nerves are getting affected. They are not functioning properly due to the deficiency of vitamin E. And why is that there is a deficiency of vitamin E? Because the individual is unable to absorb this vitamin E from the small intestine. Then there is iron deficiency anemia. The upper layer of the small intestine has got destroyed due to the immune response. The immune response was given by the deaminated glutamine, and it causes T cells to release, and T cells now have destroyed the upper layer of the small intestine, and it will lead to loss of blood, and the loss of blood will lead to iron deficiency anemia here. After that, other features, the patient is also suffering with amenorrhea, infertility, impotency. What is amenorrhea? There is loss of menstrual cycle for more than 3 to 6 months. You can refer it as to amenorrhea. Infertility, the patient is not able to produce a child after 2 years of unprotected coitus. And then there is calcification in the brain with secondary hyperthyroidism. Calcification in the brain with secondary hyperthyroidism due to this is the atypical symptom. This is the other features of atypical celiac disease. Hyposplenism, presence of Hubble-Jolly bodies. What are Hubble-Jolly bodies? You know, how does the RBC look? RBC is a biconcave discoid shape structure. So whenever you will take serological test, you will see these structure which is anucleated has presence of nucleus-like appearance in the center, purple color appearance in the center. If you will see this in serological test, you will basically predict that there is a presence of Hubble Jolly bodies inside the blood. If Hubble Jolly bodies are present, the patient is suffering with atypical celiac diseases. If vitamin A absorption is decreased, the patient have follicular hyperkeratosis. If protein is malabsorbed, he is suffering with edema and ascites. Cryptogenic cirrhosis, if LFT levels are raised, it is cryptogenic cirrhosis. Okay. Then there are other symptoms which are associated with this disease. So there are basically defined associations and there are probable associations. In defined associations, what you will take? You will take two things. It will affect majority the skin and then it will affect the system. If the skin is affected, what you can say? It has dermatitis herpetiformis. Dermatitis herpetiformis is present. So there are skin lesions present, papillovascular lesions in the exterior aspect. If there are presence of papillovascular lesions in the exterior aspect, such as elbow, such as knees, then you can say is suffering with dermatitis herpetiformis. Linear IgA deposition is seen in the dermoepithelial junction. This you will see in biopsy. If there is biopsy, then you will see this linear deposition of IgA. Here, basically, the system in systemic part, the immune system plus the genetic system plus the renal system will get affected. Now the space is very overcrowded. Let me raise these things. So in systemic part, the Down syndrome and type 1 diabetes mellitus, the immune system, sorry, the genetic system is affected. This is due to mutations. In IgA nephropathy and IgA deficiency, the immune system plus the renal system is getting affected. In hypersensitivity pneumonitis and lymphocytic colitis, the immune system is getting affected. In cerebral calcification with epilepsy, here the neural system is getting affected. That's it. Then there are probable associations. Probable associations: cryptogenic cirrhosis, idiopathic short stature, refractory iron deficiency anemia, cerebral ataxia. You will think that if these symptoms are present, the patient might have been suffering with atypical celiac disease. But no, it is not like that. In atypical celiac disease, you might see these symptoms such as cryptogenic cirrhosis, you can see idiopathic short stature, you can see iron deficiency anemia, you will see cerebral ataxia. But if you see these symptoms, you cannot directly say that you cannot come on a conclusion that the patient might have been suffering with atypical celiac disease. And that's it. And In the diagnosis part, there are two tests that are present here. First is the serological test, then there is biopsy test. In serological test, majority there are four tests. One test is eradicated. This is the anti-gelatin test. This is not used in the clinical practice right now. This is obsolete test. Low sensitivity and low specificity is there inside this test, so it is eradicated now. The most important test is anti-TTG test. Anti-TTG test. Here we will be looking for IgA antibodies. It is most common diagnosis and a monitoring test. It will help in diagnosis as well as monitoring. It is high sensitivity and high specificity. Specificity. Anti-endomysial antibody test. Here also we will see IgA antibodies. It is highly sensitive but poor specificity, done by indirect immunofluorescence. I will tell you that you have no need to learn this tests. You just have to recite the names, you just have to recite the inference. But if you will go on the clinical aspect, that how is it happening, why is it happening, so that is the work of a lab technician. You should be remembering just this test is required, this antibody is tested, and this is the inference. That's it. Disadvantages in anti-endomysial test: it is subject to interpretation and cumbersome process. Like it is a very heavy process to do. Anti-deaminated glutamine dipeptide (IgG) done in the patient when the IgA is deficient. Whenever the IgA is deficient, we will go for the testing of IgG, and the test name is anti-deaminated glutamine dipeptide test. The biopsy finding. Biopsy finding is localized to the mucosal layer. We will go and invade the mucosal layer. What we will see there? If the villus are degenerated, we will say villus atrophy. If the uh, villus are degenerated, villus atrophy. But if the crypts are having dysfunction, we will say, okay, the crypts are getting hyperplasia. The thickness in this biopsy, you will see it will be normal. Like mark score will be 0. If the mark score is 0, the thickness is normal. If it is in negative, the thickness is less. If it is positive, the thickness is more. You don't need to remember this because it is not at all important, but just for general knowledge, I have told you this thing. Then there is lymphocytic infiltrate present in the lamina propria. Lamina propria is just a thin layer present in the small intestinal mucosal layer, and you can see lymphocytic infiltrate there. Vascular degeneration of the surface epithelium. It is not specific, but there because the surface layer can get degenerated due to acid, sometimes due to ulcerative colitis and other diseases as well. But in celiac disease also, this layer will get damaged, and this will lead to iron deficiency anemia due to loss of tremendous amount of blood there. So the vascular degeneration will be seen in the epithelium. What will be your interpretation? There are four conditions: serology positive, biopsy positive, serology negative, biopsy negative, serology positive, biopsy negative, and serology negative, biopsy positive. These four conditions are there, and with help of these four conditions, you will be like predicting if the patient is suffering with celiac disease or not. So first of all, you will see serology is positive, biopsy is positive, for surely is suffering with celiac disease. There is no doubt in this. If the serology is negative, biopsy is negative, not celiac disease, but he might be suffering with the latent celiac disease, because latent celiac disease, I'll tell you, the genes are present in the person of HLA-DQ2, DQ8. If these genes are present, he might be suffering with latent celiac disease, but he is not at all suffering with the celiac disease for an instant right now, after seeing that the serology is negative and the biopsy is negative. If the serology is positive, but the biopsy is negative, you can surely say that you should do a repeated biopsy, because it never happens that the serology is positive and the biopsy is negative. If it is happening, your if equipments are faulty, but you should do repeated biopsy, and in repeated biopsy, surely you will get the repeated biopsy positive because the serology is already positive. After that, if the serology is negative but the biopsy is positive, the person is not suffering with celiac disease. But from this, we can get an inference that if the serology is positive, it is sure shot that the patient might have been suffering with the atypical celiac disease. But if the biopsy is positive or negative, it is irrelevant of the fact that the patient might have been suffering with that disease. But if the patient is suffering, has biopsy positive, you can tell that okay, there might have been something wrong inside the body. So you will tell that he might be suffering with tropical spear or cow's milk intolerance. So that are the inference that you can make with the biopsy and the serology of this thing. And there are complaints and treatments. What are the complaints? If you see refractory celiac disease, then it is a pre-malignant condition. The individual is not recovering after stopping the gluten diet. It will move to the refractory celiac disease, and it is a pre-malignant condition here. The patient might have a high risk of getting cancer. The risk of getting cancer is like small intestinal adenocarcinoma, esophageal squamous cell carcinoma, enteropathy associated T cell lymphoma. T cell lymphoma is the most common. The patient might have been suffering with this if the celiac disease is not getting recovered. So, what will be the first line of treatment? First line of treatment will be that you should restrict gluten diet and make the diet gluten free in an individual. So, you will first restrict the wheat, barley, rye, and oats. After that, you will induce rice, corn, maize, potato, soybean. Like the patient should not suffer with the malnutrition if this gluten is getting dried. So you will allow the patient to eat this rice, corn, maize, potato, but still the patient is suffering with this disease and he is not getting recovered. What will be your prescription? You will prescribe steroids for this purpose. Refractory celiac disease requires steroids to get healed. And that's it for today. Tomorrow we will be moving on with Wilson's disease and tropical spear.